inversion. But when we think about an inversion ankle sprain, it's actually a combination of movements to where it's inversion with plantar flexion, right? So if you think about when you tuck it over, you can go purely that way, which is going to isolate your calcaneofibular ligament, your CO. But usually when we're spraining it, we're going forward over it to where it's plantar flexing while inverting. Mm-hmm. And that's targeting that ATFL that sits up high above the sinus tarsi. Okay, so the last piece that we have are these intrinsics that are inside the foot. So we can peel off. What are we peeling off? What is that guy? What is that? Plantar fascia? So that big band that goes, a fascial band that goes from the calcaneus forward to the balls of the feet. Plantar fascia. So, non-contractile because it's a fascial tissue, it's not a muscle. And that leaves us with a whole series of other little stuff in here. Apparently no. Okay, so we pull off the plantar fascia, non-contractile. Where have we talked about this before? Why have we talked about the plantar fascia before? Ooh, love the windlass test. So what is the windlass mechanism? Have you heard that term before? Yeah, somewhere back there scraping in the back of my head. Or have you heard windlass before? The windlass test specifically is an assessment for plantar fasciitis. So we're not in lower yet. So what is the windlass mechanism involved? So we have this plantar fascia that goes from the heel, from the calcaneus, forward to the balls of the feet. So it is one of those static stabilizers for the medial longitudinal arch. Oops, that's it, medial longitudinal arch. So we had 4 static stabilizers for the medial longitudinal arch. The plantar fascia was the most superficial. When we load it, when we load our foot, we want it to be somewhat supple, to be somewhat soft. Because we want it to absorb some of that load. So the arch is. If you put pressure on the balls of your feet, if you put load on it, your arch will flatten out. That gives us that venous plantar pump, that venous pump to where we're stretching the veins, forcing the fluid to move up and out. But as soon as we want to transition into walking, we need it to be rigid. So as our big toe flexes, well, extends upwards from the load. As our big toe gets pushed and bent, as we lift our heel, take off your shoe, look at your foot. Look at your foot. Look at your foot. Stare at this thing. Cross your foot over, and I want you to extend your big toe. Look what happens to the height of your arch when you extend your big toe. Soon, now take your finger and actually pull your big toe up, like as if you're walking. Because if you do that, if you pull it into extension, it increases the height of the arch. It increases the rigidity on that arch. So by rolling that distal phalanx, that proximal phalanx, into extension on top of that metatarsal, by rolling that big joint up, it's pulling that plantar fascia, except it's not really a contractile tissue. It doesn't stretch a whole lot. So if you're putting tension on it, the only way to get it to do that, the only way that this, if I pull on one way, is that it's going to create some bowing in your foot. The bones become rigid through that plantar fascia. By putting that extension in that toe, it's cranking this and making it tight. And the only way, the response that you can have when this gets tight is to increase that rigidity in the arch. So the windlass mechanism, it is that extension of the big toe that increases the rigidity on that medial longitudinal arch. Okay, so getting past that, that last piece that we have to work on is these muscles that exist in this foot. What other activities, what other... Okay, so what motions do we need to have in our foot? So that's ankle, so subtalar joint. We have inversion, eversion, plantar flexion, dorsiflexion. So when we get to the foot itself, though, what else do we need to do in here? What are these muscles working on? Where do they go? What joints are they crossing? What do they do for us? What's left? We've dealt with ankle. Most of that's lower leg stuff. So the intrinsics in the foot, what are they doing? Yeah, I mean, it's just like your hand, right? So we're going to abduct and adduct our fingers and toes. We can move our fingers, right? We're going to do the same thing with our toes. We can splay them out. We can pull them back in. We don't think we can do it quite as much as our hands, but the muscles are largely there. So we're doing things with these muscles that act on our toes. So that's the last piece that we have to focus on, is what this is doing with our toes. Now let's orient ourselves a little bit, because there's some unique little boogers and pieces in here. When we talk about abduction and adduction, what is that about? What does it mean to abduct your arm? Away from what? The midline of what? Of your body. Good. So if I'm abducting it away, I'm pulling it away from the midline of my body. When we do hand and foot, it's a little bit different. When we do hand and foot, it's on the midline of the hand and the foot. So in the foot, that means the second ray. Each of these rows, these lines of bones, we reference as a ray. So each of these metatarsals going into the phalanges is a ray. The midline of the foot is the second ray. Okay? Now that becomes important when we get down to the fourth layer. So if we're talking about abduction and adduction, we're abducting and adducting towards and away from the second ray. Cool? Cool. All right. So, we're going to go superficial to deep on this foot. Superficial. This guy right here in the middle. Flexor digitorum brevis. We had a longus. What compartment was flexor digitorum longus in? I have 3 calls for posterior. Can you get more specific than just posterior? Because there's not just one posterior. What are my options? Deep and not deep. Deep and not deep, right? Deep and superficial? All right, so which is it in? Flexor digitorum longus, which compartment is it in? I have a deep, superficial, and a not deep. A deep, a superficial, and superficial. Ooh, superficial. Superficial. Deep. Okay, we have a 2 versus 4, and my 2's winning. It's deep. So what's our superficial compartment? Is your triceps surae. That's your gastroc. It's your calf. You got it? And the ones sitting on the outside are the ones we can see very easily. Your calf is just cut when you're looking at people, right? And your soleus is underneath it with that plantaris, triceps surae, Achilles tendon. That's your superficial. So deep, we get into Tom, Dick, and Harry. So tibialis posterior, flexor hallucis longus, flexor digitorum longus. So this is flexor digitorum brevis. Compartment 1, flexor digitorum brevis. Still hopeful I can get my toys to work today. All right. So, nice guy sits right here, no big deal. Chills out and helps flex your toes. 2 more muscles. 2 abductors, abductors. Abductor hallucis. So he abducts the big toe. And abductor digiti minimi. Abducts the mini toe, the miniature toe, the little toe. So they sit on the outsides. Okay. So those abduct away from the midline, away from the second ray. All right. That's it. That's it for compartment 1. Flexor digitorum brevis, abductor hallucis, abductor digiti minimi. Layer 2. Layer 2 is probably my favorite. Now, I'm not really going to pick and prod about too much in origin and insertion for the intrinsics in the foot. So recognize what they do, and it's largely found in their names. So abductor hallucis abducts the hallux. Not crazy hard on these, right? Now, layer 2, I like just because he's fun. I like my origin and insertion on layer 2. Yes, ma'am?
Abductor hallucis and the brevis are layer 1?
That's layer 1. That's the most superficial. Going from not deep to deep. Superficial to deep. Okay? Alright. Layer 2 is really fun. So, it's this guy right here. So it all comes off in one lump and piece when you pull on this model. And what you'll notice is this tendon that comes up and splays out. What does that look like? What muscle tendon is that? I'll put it back on so you can see it. Maybe. There we go. So it's back on. So we're talking about this guy right through here that comes across the foot. What tendon is that? Where does it go? And just look at it. I mean, you don't have to guess. Just look at where the tendon goes and make an educated guess. It's one thing you guys get so stressed about is, that's a question. And what I need you to go is, okay, look at where it goes because it's telling you its answer. This long guy starts from outside of the foot. So it's not an intrinsic muscle that we're talking about. So it starts from away from this area. So probably not a brevis for that reason, because it's coming from above the ankle. It's a lower leg muscle. And then look at where the tendons go. Where is it going? Each of the 4 toes. Yeah? So digitorum, we can pull that. It starts outside of the foot, so we're going to give it a longus. And it's a flexor because it's on the bottom of the foot. Yeah, flexor digitorum longus. So you can piece it together, work your way through it, see where it's going. Does it look short or does it look long? It looks long because it's starting from, you can see the tendon run all the way up and above the ankle. Okay, so flexor digitorum longus tendon has some really cool little pieces to it. There's this huge muscle called Quadratus Plantaris. Quadratus Plantae. There we go. Quadratus. 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 And then plantae, meaning the foot. So quadrate, it looks like a rectangle. I mean, it's kind of squarish in shape, straight edges. Plantae. It starts on the calcaneus, but it inserts into flexor digitorum longus tendon. Well, that's kind of fun and random. So when it contracts, it's actually helping to pull that tendon in the foot. So it's a whole second muscle acting on a tendon to help yank it when it needs to. Cool. So it inserts in that tendon. Now, originating from it are these little guys right here. So they're originating from that tendon and then going up to help bend the toes as well. So we've got a whole other set of muscles that are geared to help assist flexor digitorum longus. Well, that's weird. These guys are called lumbricals. L-U-M-B-R-I, lumbar, C-A-L-E-S, lumbricals. Yeah. L-U-M-B-R-I-C-A-L-S. So I had to look up the root to the word. I'm like, where does this word come from? What does it mean? Because again, most of these things, I mean, quadratus is referencing the fact that it's a quadrate. It's kind of a rectangle shape. That's 4 sides that are kind of straight and squarish. We'll see that term quite a few times because there's a few quadratus in the bottom. So quadratus plantae. Plantae means it's from the foot. Flexor digitorum longus. Flexes, it's the digits, the toes, and it's the long version. So where the heck does lumbricals come from? The fun answer? It means worms. So whoever dissected this the first time thought these little wiry muscles coming off of flexor digitorum longus looked like worms. Awesome. So layer 2 has quadratus plantae and worms. Lumbricals. Good to go? Awesome. Layer 3. Layer 3. Flexor hallucis brevis. Oh, we may have it. Maybe. Oh, that's my friend today. I love this thing once it's working. It's so much better. Hopefully it stays. All right. So, flexor hallucis brevis. Intrinsic. In the foot, short muscle. Flexes the big toe. Flexor digiti minimi. Flexes the little toe. We have an adductor hallucis. Adducts the big toe, pulls it back in towards the midline. What's the midline? Second leg, second toe. There's a transverse, so a sideways, and an oblique, a diagonal head. So transverse and diagonal. That's it. Awesome.
Wait, what was the muscle before that?
What's that?
The muscle before that? That pulls
So
away?
flexor hallucis brevis, flexor digiti minimi,
Okay.
and then adductor hallucis.
And then
There's
that's where
a transverse, there's two heads, one oblique and one transverse.
Okay.
And those last three, four, whatever you want to call them, in its own compartment, like starting with the flexor hallucis brevis, or layer, sorry.
That's layer 3.
Okay.
Now, this is kind of fun, but we have, what's a sesamoid? It's a big sesame seed. What's a sesamoid? Definition and more specifically, more importantly, it's a bone. Huh? Joint? They usually sit around joints. They usually sit around joints or at joints. So what's unique about a sesamoid? It's a floating bone. I like that. It's a good term. Floating bone. Why is it floating versus not floating? So how are most bones usually connected? When we talk about joints, what stabilizes that joint? What connects two bones together? We look at the knee, and what do we see? Ligaments. MCL, LCL, ACL, PCL, ALL, lots of short little 3-letter acronyms, right? We look at the ankle, ATF, CF, PTF, deltoid. Okay, so bones are usually connected to other bones by ligaments. What's different about a sesamoid? How is it connected? Where do they sit? Why is it floating? If it's not by ligament, then it's by something else. What's the something else? Love tendons. That's a great answer. So we can slide back, and all of a sudden you see you get your patella, and your patella's got floating between the distal quadriceps tendon and the patellar tendon going to the tibial tuberosity. So it moves because it's embedded within a tendon that moves because it's connected to a muscle, which, again, muscles are dynamic, ligaments are static, passive. Okay, so the reason for that diversion is that down here, so plantar fascia, we can make it go away. Oh, I'm so happy. And we see these two cute little guys right here. Sesamoids. So under the big toe, we have this pair of sesamoids. And if you look at my little model right here, we actually have this cool little groove that sits right in here. So the sesamoids are sitting up above that groove. They're kind of creating that groove in a way. And they're embedded within flexor hallucis brevis. So in this muscle right here, we have two extra little bones that sit on either side of this little bit of a groove. Through that groove is flexor. If he wants to go back together. There we go. Is flexor hallucis longus. So we have a pair of sesamoids right here and here. Through the middle, we have flexor hallucis longus. So if I slide that back in, then you can see there's the sesamoid there and there. Flexor hallucis longus splits right in between them. So if you go up on your toes, if you lift your heel up on your toes, if you wear high heel shoes and you're putting a lot of pressure on the balls of those feet, you're putting your load into the sesamoids rather than crushing flexor hallucis longus. So it gives us protection for that very strong, powerful tendon to do its job in holding us up. And those are embedded within brevis, flexor hallucis brevis. So there's kind of two heads, splits on that distal insertion, so that we have a way to put a pathway for longus to slide in between. Okay? And then adductor, and then flexor digiti minimi. Awesome. Fourth layer. So let's get rid of that. I'm going to dig for a minute so I can get rid of stuff. So there's brevis, flexor hallucis brevis. There's oblique head and transverse head of adductor hallucis. Flexor digiti minimi. And so deep, we have these muscles that sit in between the metatarsals. So the term that we're going to look at is interossei. There's plantar interossei and dorsal interossei. And the way to tell them apart, pad, P-A-D, and dab, D-A-B. Pad, plantar, adduct. Plantar, pull it back towards the midline. Dorsal, D-A-B, dab, dorsal A-B duct. They pull them away from the midline. So by understanding that, you can put the logic to start piecing together where they are. I just touched on the plantar interossei. How many of them are? How many do you see highlighted? 3. So I have 3 plantar pad, adduct, 3 that pull it back towards the midline. How many toes do I have? I have 5 toes, I think, for most of us. Right? And some people have pterodactyly or whatever it is, that there's a 6th digit or whatever. But okay, so most people have 5, right? Okay. 5 toes, why don't I have 3 muscles? Why don't I have 3 adductors? So what does it mean to adduct? Plantar, adduct, pad, right? So we're going to adduct. We're going to pull it back towards, what does it mean? Back towards the midline, back towards the 2nd toe. We have it on toes 3, 4, and 5. So each of these, we have the capacity to pull back towards the midline, back towards the center toe. Why do we not have a plantar interossei on the big toe? Not longus. What muscles are in the 3rd layer? Flexor hallucis brevis, flexor digiti minimi, and adductor hallucis. We already have a whole 2-headed monster geared to pull that toe back in towards the midline. It has its own. Adductor hallucis, a transverse and oblique head, man, he's all kinds of hooked up. He's all set. He doesn't need a little plantar interossei. I don't need that stuff. All right, so why do we not have an adductor plantar interossei on the 2nd ray? It is the midline. I can't pull something back to itself, right? So it is the midline. Now this is going to be the exact same story when we get to the hand. there are lumbricals in the hand, pad and dab in the hand, interossei. It's going to be the same exact story. The only difference is that the midline is the third finger in the hand, not the second ray. So if you have a hard time grasping this, then fix it now, because you're going to see it again. Okay? So, pad. There's 3 of them, because they're pulling 3rd, 4th, and 5th in towards the second ray. So dab, dorsal, interossei, abduct. Can we try to work out how many you think there's going to be? How many dorsal interossei muscles do we need to have? I have a vote for 6. I have a vote for, there we go. Why are you so obsessed with the opponent's teaching your name? We're not even talking about that muscle. So I got a 5, I got a 6. I have 5 toes. I got somebody trying to count muscles on my foot.
I'm trying to like picture it.
I think it's 5.
5? Okay, good. I have a 6, I have a 5. Did somebody say 4?
I think 4.
You said 4. Why do we have 4? Let's we're going to do this. Why do you say 6? We'll put you on the spot first. You spoke first.
6 for abduction and 6 for...
Okay, so we
I
have...
mean 3 and 3. Or they're not the same. I don't know. I don't know what I'm doing.
Let's work through it. Why do you say 5?
Well, in between the Interossei, there's like muscle in between, so that's why I figured 5 on, the
So-
attachments.
Okay, so you're saying...
Yeah.
About as much clarity. Say it again. Good.
Yes, I'm saying that in between where the Interossei is.
1, 2, 3, 4.
Yeah, I think there's, well, it could be one hidden, but it's not necessarily. I say 3.
She says 3.
Yeah.
Why do you say 3?
Because there's 2 adductors.
So there's 3 abductors. So we had 1 on 3rd, 4th, and 5th. So 3 adductors, 3 that pulled you back towards the midline, right?
Yeah.
So 3 pads, 3 plantar interossei. We want to know how many dorsal interossei we have. Dorsal abduct. Again,
Yes.
why 4?
Because there's already one for the big toe.
Okay, so what is the second ray?
Midline.
Second toe, right? How many ways can you move the second ray away from the midline? Now it is the midline, so I can't move it towards itself. But can I move it away from itself, away from its normal position? Yeah, I can move it that way or that way. So it actually has 2 all by itself. What about the 3rd? Can I move it away from the midline?
Yes.
Yes. What about the 4th? Can I move it away from the midline?
Yes.
Yes. What about the 5th? Can I move it away from the midline?
Yes.
Yes. What about the hallux, the big toe? Can I move it away from the midline? So in theory, I have 6. In theory. Except, go back, what's the correction?
But how good is this?
The hallux is different. Why is it different?
Because it has its own.
Where? What layer is its own in?
The first.
No.
3rd. Wait.
Abductor, right? Yeah. In the first.
No. Oh, 3rd. And
No.
first.
First. Oh, goodness. What else is in the first? So we're going to take 1 off because we have abductor hallux in the first. We're back down to 5.
Abductor.
Oh, and we have an abductor digiti minimis, so we're down to 4.
Yeah.
So if I go and touch it, we should see 4 little things light up.
Yeah.
Right? All we're doing in this area is 2 motions. 2 degrees of freedom. Abduction, adduction, and flexion, extension. right? So layer 1, flexor digitorum brevis, and then abductor for hallucis and digiti minimi. Layer 2, we're assisting toe flexion by grabbing onto flexor digitorum longus, quadratus plantae, and the lumbricals. Layer 3, adductor hallucis with its 2 heads, and then flexor hallucis brevis, and flexor digiti minimi. And then layer 4, pad and dab. And pad and dab are just adductors and abductors. Plantar interossei, dorsal interossei. So, the better you are with this, the hand will be a breeze for the muscles because it's the exact same layers. The only thing we add in is opponents, which is opposition. Opponents pollicis and opponents digiti minimi, so that we can roll them in towards each other. That's it. I'm all done. I'll see you later. So, I don't need to pound you with origin insertion on all this. Things that I like to know, again, I think this guy's just cool. Layer 2, he's just fun. The fact that he is so ingrained into a tendon, you're going to see that again because the lumbricals in the hand are the same way. They're coming off of a tendon and inserting into bones. That's just, again, it's unique. But in the foot, so flexor digitorum longus has lumbricals and quadratus plantae coming into it. Yay, fun. How do you study? So we have an exam in 2 days. If you haven't been studying, then say a prayer and get to work. Or say lots of prayers, but don't pray too long because you need to study. Okay. Right? Okay. If you are feeling lost, then speak up. Find a friend. Study with folks. Quiz each other. Okay? There are practice tests online. So it is 2016. If you go back to my first 2 years in the program, way back when, I love anatomy and I love abusing people with anatomy because I think your anatomy should be better than most people's. I think understanding orthopedic injuries and conditions requires you to understand anatomy. I think upper and lower eval, you should, by your sense of anatomy, know 90% of what's wrong with a person before you ever touch them. Simply because you understand the anatomy and how it gets injured and how people talk about that pain. So the stronger you are here, the better of a diagnostician you'll be, so I push it hard. Cool? But it's not my intent to make it a weed-out class. I say that, and several of y'all have seen me before. Right? I want you to do well with it. Anyways, go back 3 and 4 years, and the exams I gave were open answer. I ask questions, you write answers out. And then I switched over to multiple choice, sorry. But apparently it was multiple guess because it really didn't change grades. So even with the answer in front of you, people didn't significantly bump or change in their overall grades. So I don't really care. I will tell you what I want you to know. I want you to know the muscles of the quadriceps. I want you to tell me which one's different and unique. All of that is in those practice tests that are online. My testing style, and for those of you who have seen me before, I mean, you can verify that the tests that the practice test that's online is very, very much like what you're going to see on there. I'm not kidding when I say you need to know the muscles of the quadriceps. You need to know the muscles of the hamstrings. You need to know the compartments of the lower leg. The way I teach it is how I test it. So where do you start? Because it's a tremendous amount of information and it kind of hurts your brain sometimes to go, what do I do and how do I start with all of this? If I'm going to ask you what the insertion of the vastus medialis is. Don't say it, but can you raise your hand because you know the answer? Insertion of vastus medialis. I say, don't say it. Ah. All right, now pick a new one now. What is the insertion of the vastus lateralis? Come on. If you know it, raise your hand. Raise your hand. We're going to fight. You and I are going to step outside. I'm going to go full judo.
And then like,
I think I'll lose. I've seen her fight. Anybody that walks up and shows you YouTube clips of their last competition, yeah. I think I'll lose. All right. What do you need to know to answer that question? I mean, one way I could say, know the vastus lateralis, and you can just automatically pull up, well, the origin is this and the insertion is this. But to know that answer, you need to know where it is, what muscle group it's in. And it helps to know what muscle group it's in. And then you need to know what bones or what joint it crosses, and what bones are on those, and then what landmark is on each of those bones to be able to make that. So there's really, as simple of a question that is, as that may be, there's a lot of foundational knowledge that you need to get to that point, okay? So the answer is what? Tibial tuberosity, okay? What bone is that on? Tibia, right? So it's the tuberosity of the tibia, so tibial tuberosity, okay. What muscle group is vastus lateralis?
quads.
Quads? Quadriceps, okay. And what action does it have? Or what joint does it cross? We'll start there. What joint does it cross? I have a flexion, I have extension, I have a hip.
No, yes, it's
Quadriceps, cross both joints. Vastus lateralis, though, crosses one joint. Okay? So the quadriceps mainly act where? What joint do the quadriceps mainly act on? The knee. The quadriceps act on the knee. What do the quadriceps do at the knee? Extend.
Extension.
Straighten it out, extend it out, right? So the quadriceps extend the knee. Good. Right? Okay, so a way to study is to pick a joint and start at the bone level. Get rid of all the scary muscles. That's much less intimidating. And just look at the bone. Go, I'm going to talk about the knee. Take a whiteboard, something you can erase, and draw the bones of the knee. Go for it. You get a whiteboard. You got markers. Sorry, I would have brought in a whiteboard. That's not loud in my. Once you slide on this side.
Yeah.
Or if you want to use the front boards, you can use it too. That's good. That's all right. I mean, again, your drawings may stink. They may be absolutely atrocious, and nobody ever cares. So something I would encourage you is get to that point, draw it, put something out, and then draw a little arrow, or you draw it and then you challenge your friend to label it, or you label it. So give me the names of the bones.
of the muscle.
Okay, so, but I would do that next. So once you have a rough drawing and you have them labeled, right? Then draw in, take a different color, and draw in the muscles. So I wouldn't even worry about origin insertion at this point. I would want to know, well, okay, hold on, let's take the knee, draw the bones. Then quiz yourself on degrees of freedom and degrees of movement. So how many degrees of freedom at the knee? 2. What movements are those? Flexion, extension, and rotation. What planes do each of those movements? So again, always just keep reinforcing the foundation. Degrees of freedom, there are 3 possible based upon what planes? What planes do we have to worry about? Frontal, sagittal, transverse. So we have 2 degrees of freedom at the knee. We have flexion, extension. What plane is that in? So it's your movement is staying in contact with this large sheet of glass the entire time. So frontal is here. So to stay in contact, what motion is that? Adduction, abduction. Did we say anything about that in reference to the knee so far? No, we did not. So sagittal is here. What motion is this? Flexion, extension. So flexion, extension in the sagittal plane. Rotation, what's left? Transverse. Now, we can get funky because if I take rotation here and all of a sudden shift it to here, I have changed that rotation. Right? So rotation's kind of squirrely, but in this reference, we're dealing with transverse plane as the tibia rotates underneath the femur. Now, degrees of motion for each of those. So how many degrees of motion do we expect to have for flexion extension? How many degrees measured do we have for full extension? So full extension is
140. Right.
Full extension is what? Full extension is
30.
just throwing numbers out like UMK right now. So focusing at the knee, if that's the center of rotation, that's 0 degrees. Full extension is 0.
Okay.
Because your point of rotation is here. Now, how far can I flex it? So 90 goes to here, and I can go up to here. So the answer is, ish, depending on the person, 140. So 0 extension, 140 in flexion. Okay? So it's these details. Just walk yourself through this process as you study. And where you trip, where you don't quite get it, take a piece of paper and write a list. Knee, 140 degrees flexion. What's the end feel? What's the end feel for flexion? We have to know our options. What are our 3 options? Soft, firm, and hard. And bony is the hard, right? Soft, firm, and hard. So, what is our end feel for flexion? You got, and again, stop for a second because you're racking your brain, but you've got your own bodies. Bend it. How does it feel? It's soft. You've got muscle there. So, again, just work your way through some of these questions. Slow down and take your time. Take a piece of paper in there and write this out in there. I don't even care if you bring a whiteboard in there and want to just sit there and draw stuff out. I don't care. I want you to work your way through this process. doesn't have to be soul memorization. The more you can work your way through it, the easier it becomes time and time again. So, soft end feel. Brilliant. What about extension? How is that one? So if it's hard, you got to tell me what's the restriction to extend it. Where's my bony block? Hinge joint. This one has no bony block. What's the restriction? What's the limitation? What limits how far out this can go? It's your ligaments. A ligament as an end feel gives you what of my three options for end feels? Soft, firm, or hard? Nod your head. I asked a question.
My bad.
Is it soft, firm, or hard to have a ligament as an end feel? Have a ligament as a restricting tissue. I mean, hard is bone on bone. You mean hitting my head into a wall. Firm. Soft is muscle on muscle, squishy. Ligaments, pulling a rope tight, that's firm. Okay? All right, so again, if that's where you have a mistake, take your paper and go, okay, so end feels on the knee. I need to give more love to those. I'll just title the page, things I need to give more love to. End feels on the knee. Next range of motion, next degree of freedom. So we said rotation, which is in the transverse plane. What is that called? Because it's very unique. What is the name? Screw home mechanism. And then all of a sudden we can jump onto this whole other realm of what is it? Why do we have it? What does it do for us? I think it's part of the same questions I just asked. How do we undo it? Popliteus undoes it. What's the major component of why of how it happens? Medial condyle is larger, so it rolls farther, so that tibia externally rotates. Right? And the popliteus unlocks it. Why do we have it? What's it do? What is the function of the screw home mechanism? So we don't get tired. So we can stand upright without firing our muscles. Sweet. Good to go? I don't know if you're normally quiet or if you're just trying to keep up. It's all good. But I want you to recognize where that is, so if we can help or we can tie you in with somebody in that process, that we make sure you're not getting behind. Okay. So I need to know if it is because you're just not quite with us and it's not, or you're just a person who doesn't spit out in class. So I want to make sure you're doing all right. Because a lot of your classmates, it's their second go around playing with me. So part of this is refresh on their part. Okay. So we're going to learn each other and we'll figure this out. Question. Who in here is AT? You're in that world. And you're rehab science? Okay. All right. Good to go. Tier 2 applications are due what date?
Did we submitted them last semester?
Then they should be good to go.
Yeah, because I emailed her and she said that if we had already done it last semester and our packets were complete, then we're fine.
You're fine. Okay, just making sure.
And then in case anyone has had the problem, like the acceptance thing or whatever, went to my, not to my inbox, to the other one. So like a spam. So I never received it. But I'm already in the program.
Oh yeah,
so,
mine too.
Good to go. Okay. I just want to make sure that everybody's good and on the same page.
Remember I told you I never got that email?
And she wants, huh?
No, remember I told you when she forwarded.
Oh, and Friday. Museum. Whitty Museum?
Yes.
Or Saturday, it's your choice. So 8:30 to 10. The directions are up there. If you have questions, let me know and I can help get you there. I will not be there. My daughter decided to try to face plant in the pool, and normally that'd be a soft watery cushion, except there's a tile ledge under the water that she chipped her tooth on. So I get to hang out at the dentist that way, so I won't see you. But You're looking for Joanna Rosales, Amanda Brown, or Dr. Brian Bales, who, by the way, speaks fluent Mayan. Who does this? Like, what is this? The guy, yeah, no, cool. I love it, but blows your mind. Great energy, good people. They're going to walk you through what's expected, all that kind of stuff.
So
Friday from 8:30 to 10.
okay, Saturday.
So if you want to get involved with that, you can. It's entirely up to you. Because you didn't before.
Yeah.
Did you?
Never.
No. So the nanomodge table is like a 5-foot iPad.
Oh,
And so they have one. It's $100,000, $80,000
oh wow.
medical. They're using them in Harvard Medical School. I mean, they're using them as, they're really cool things. They need docents. They need people who volunteer
Okay.
to lead the general population on what it is in the human body using that tool. So it's an orientation to do that. So if you desire, then you can go. I don't know if you have community service you need to get done. Oh, okay. Well, it's entirely up to you. But it's kind of cool. And you guys all have free access to the witty in general.
Yeah.
So you can go study on it
Okay.
anytime you like to as well. Part of this is to give you an experience working with it as well. Okay, so flexion, extension of the knee. What muscles create flexion of the knee? Extension of the knee. What muscle creates extension of the knee? What muscle group? Quadriceps. Brilliant. So at that point then we can step off into, we went from the bones of the joint, we went to the degrees of freedom to a specific degree, which was flexion extension within the sagittal plane, and then what muscles create the extension, and that gives us the quads. Now you can go and task yourself with what muscles make up the quadriceps and give yourself the names. And then I would group them the best as possible and go, okay, so how did I learn these? Well, 3 of them are named vastus some or others. So they're common because they have not just the name, but the same origin. So they start on the femur and go to the tibia. So the same origin, the same insertion, the same action. So that's like 3 pieces of information rather than 6 or 8. So group things the best you can. The one unique booger is rectus femoris. Oh, how is it unique? Quiz yourself. What's unique about rectus femoris? It's spelled differently. No. It crosses what? What else does it cross? What is unique about it? I can either say its origin is different or it crosses an extra joint. What's the other joint? Rectus femoris crosses what joint? The knee and the hip. I mean, it's either the one above or the one below, so it's the hip or the ankle. So quadriceps, right, comes up, starts on the hip. So then you can go and refresh yourself and go, all right, so all of the quadriceps, so 3 of those muscles, all the vastus originate on proximal femur.
Oh, so
Intertrochanteric line. What?
What if the ischial tuberosity? That the rectus originates?
What's that?
The ischial tuberosity?
No. So then we got to go back on our little piece of paper and say things I need to give more love to. Origin of rectus femoris. AIIS. Anterior, inferior iliac spine. Now I get a volunteer, please. I need you to lie down. Right here. Sure, you're up and walking around. Sounds great. So lie on your back, please. All right, so point of the hip. Anterior, superior iliac spine. Good? Very easy to find. You take a thumb and you go below it. And you take a thumb and you go inside of it. Then that point right in there is your AIIS. So this point up here is anterior superior iliac spine. In and down by about a thumb width is the anterior inferior. So if you take your finger and you plant it right on that spot and do a leg lift, lift up, and you'll feel that contraction get tight under your finger. So you can feel where that muscle originates as it curves down and in to create the pelvic round. Okay? So anterior inferior iliac spine is palpable. You can find it. You got to put some pressure, and if you're ticklish, you're just toast. But you can feel it contract when you do it, when you make that muscle fire. What motion did I ask her to do to make it fire? What motion does the rectus femoris do at the hip?
Flexes the hip.
Flexes the hip. This is hip flexion. This, I hope I'm right, this is hip extension. I love that you confirm that all the time. Just be mindful because it's not always right. So, this is hip extension. This is hip flexion. So, rectus femoris is hip flexion, knee extension. Hamstrings, hip extension, knee flexion. Okay? So it is that process, and the more you've got to work in the beginning, the longer it's going to take you. And that's okay. So we get done with that. We've just talked about, and then what's the common insertion for all of your quadriceps? Tibial tuberosity, on the tibia. So if I ask you something like, what is the insertion of a rectus femoris? Instead of going, okay, rectus femoris goes from up here to down here, it's easier to go rectus femoris is one of the quadriceps. And they all have the same insertion of the rectus femoris. So you need to know two pieces of information rather than the insertion for 4 separate muscles. So where we do these groupings, simplify it. You flip it around and we go, okay, so we just spent time working on knee extension. We need to finish with sagittal plane motion on the knee. That's knee flexion. What are my knee flexors? What muscle group? The hamstrings. 3 of them, once again, we can spit out the names, but 3 of them have the same origin. Semitendinosus, semimembranosus, biceps femoris, long head, all originate where? Ischial tuberosity, which is the, like in your butt crease right here, in the middle, big old bone. It's your sit bone. If you're sitting down, that's the big heavy bone that's taking the brunt of the weight. Take a sport like rowing, where they're sitting on it and rocking back and forth a whole bunch, and you get a nasty little injury called ischial bursitis. So you're inflaming the bursa that cushions that spot. That's like death to a rower. Because then it hurts to sit, which kind of impacts your whole life, not just your sport. They give you a donut pad, it's all kind of funky, it makes fun of you. Anyways, ischial tuberosity, 3 of the 4. Okay, well that means there's a 4th. Where does the 4th go? Where does it originate? Yeah, it's that distal half, distal third maybe of the posterior femur. So it's like the tail end of the linea aspera. So yeah, you had it. I don't want to let me steal your thunder. I mean, it's the distal part of that. So the distal posterior femur. Now your muscles split, so that they kind of start and they kind of go wide. So the medial muscles go semimembranosus. Membranosus is medial. So medial, semimembranosus and semitendinosus go medial. So again, look at anatomy and see where they go. Membranosus is unique because it starts tying in with the medial meniscus. Oh, sorry, it ties in with the MCL. The MCL ties in with the medial meniscus. And the lateral side is biceps femoris. Goes into what structure? Where does biceps femoris insert?
Head of the fibula.
Huh?
Head of the fibula.
Head of the fibula. So biceps femoris drops down head of the fibula. What else is connected to the head of the fibula? Huh? Short head. So biceps femoris, the 2 go together into the head of the fibula. What else is attached to the head of the fibula? Huh? LCL, lateral collateral ligament, fibular collateral ligament. So where you can draw those connections and quiz yourself on those as well, to the best of your ability. Got it? All right. So that's a lot. It's just working through. Then work in. Okay, great. We've done most of what we need to do for the knee. Because you've talked flexion, extension, the muscles for all of that, the origin, insertion. But I would do it in that order because if you don't know what bones we're talking about at a joint, There's absolutely no reason for you to sit there and focus on origin insertion. You're bass backwards about everything. If you know the bones, and then you can figure out the muscle groups and then the muscles that are in the group, then you're getting to where you're at 50, 60% of the exam information. And you have to focus on details to work through the rest. So let it tell a story. Let it be a conversation that you can walk through rather than, I don't know where to start. Okay? So, Winnie, Friday. Test, Thursday. Please have ExamSoft up and running, ready to go. If you have questions and issues with it, let me know so I can help.
Will it be in the lab or here?
I don't know. I gotta see if the lab's open. These whiteboards live in room 217 on the shelf, so feel free to go in and draw. There are skeletons in 217. They're short little guys. Feel free to use them and draw. Cool?